Now we are discussing spread of oral infections from oral pathology, and our disease is cellulitis, or it is also called as phlegmon. Okay, diffuse inflammation is present here in cellulitis. Diffuse inflammation is present, spreading along the tissue spaces, facial planes. Okay, it will spread along the tissue spaces between the tissues and facial planes. Okay, infection in pulp infection occurs, then it will go to apically, and then in bone, which will cause osteomyelitis, and then in cortex, and then cortex, and then spread into soft tissue, and it will spread into soft tissue, which is further divided into diffuse and local. Diffuse is called as cellulitis, sorry, and the local is called as abscess. Local is called as abscess, and diffuse is called as cellulitis. Okay, so it is the very severe condition because it will come after osteomyelitis, and after the infection, and it will get severe and then it will occur in soft tissue after the bone involvement. Okay, etiology is streptococci. In osteomyelitis, we have seen it will occur because of staphylococcus aureus, and then after that streptococcus. But here streptococcus are the first preference, and then staphylococcus, and then bacteroids and prevotella. Okay, streptokinase, hyaluronidase, and fibrinolysin enzyme required by microorganism to destroy connective tissue. These three enzymes are required by microorganisms. The streptococci, if cause cellulitis, it will require these three microorganisms: streptokinase, hyaluronidase, and fibrinolysin by microorganism to destroy connective tissue. To destroy connective tissue, it will not cannot do on its own. It will require these three enzymes. Okay, then histopathology: diffuse, acute, and inflammation. Diffuse, acute, and inflammation, okay, is present. We Here we see inflammatory exudate, increased PMNLs, less plasma cells, and lymphocytes are also present here, but less in number. So increased PMNL, same as we have seen in acute suppurative osteomyelitis. Okay, increased PMNLs, less plasma cells. Also here we see inflammatory exudates. Okay, so treatment: remove source of infection, and then we will decompression. Okay, infection or specific tissue spaces. Okay, now we will see, not in detail, but just the names detail in general anatomy and oral surgery. We will study it further. Space infections, here we will just study the names. Infection or specific tissue spaces: important spaces in maxillofacial region, in relation to mandible. It's submandibular space, submandibular space, sublingual, buccal space, submesenteric interval, parotid space. Okay, pterygoid space, pharyngeal space, peritonsillar space. That's it. In relation to maxilla, within the lip, within the canine fossa, within the lip, within the canine fossa, palatal subperiosteal interval, buccal space is present in both maxillary antrum. Okay, maxillary sinus or antrum, infratemporal space, subtemporalis muscle interval. Okay, that's it. Now, for next disease is Ludwig's angina, special type of cellulitis. It is also it is a special type of cellulitis when three spaces are involved bilaterally: submandibular, sublingual, and submandibular. These three spaces are involved bilaterally, then we will call as Ludwig's angina. So it is very severe. Okay, acute. It is acute and potentially life-threatening type of cellulitis. Clinical features are brawny induration. Brawny induration means very hard. Okay, in FOM, floor of mouth, of because of this tongue is raised. and brownie induration is present in the floor of the mouth. Because of this, there is induration and swelling is present, so it will raise the tongue. Okay. Now plus cervical lymphadenopathy is also present, and uh, which is a cause of first asphyxia, most common cause of death, and then sepsis. Okay, asphyxia and sepsis. Mandibular second and third molar are involved. Second and third molar are involved in Ludwig's angina because their root apices are below the mylohyoid ridge. Because their root apices are present below the mylohyoid ridge, so infection perforate lingual cortex. We have seen in relation to mandible, so submental, submandibular, sublingual. So it is very fair to say that Ludwig's angina will occur in mandible only, and then in also in posterior region, because the second and third molar of mandible, their root apices are below the mylohyoid ridge, so infection perforate lingual cortical plates. Buccal cortical plate is thick. It because buccal cortical plate is thick and lingual cortical plate is thin, and the infection perforates through lingual cortical plates and thus involves submandibular and sublingual and submental spaces. Okay, lab findings are streptococci, also cellulitis, and then staphylococcus. Okay, increased temperature are present, fever, lymphadenopathy, and restlessness. If respiratory tract get obstructed, inflammation of glottis can occur. To manage such patient, emergency tracheostomy is carried out. Okay, treatment and prognosis. Before evident of antibiotics, 40 to 50% are before the invention of a discovery of antibiotics. 40 to 50% cases of this Ludwig's angina are fatal, but now prognosis is good. Remove the source of infection followed by broad spectrum antibiotics. Okay, now it's simple. Now next disease is cavernous sinus thrombosis. Okay, cavernous dental infection is carried by the way of the pterygoid plexus. Gram positive Staphylococcus, specifically Staphylococcus aureus, are usually the pathogens in this setting. Anterior maxillary teeth, mid third of the face, drain here. Cavernous sinus thrombosis means we are studying thrombosis in cavernous sinus. Dental infection is carried by the way of the pterygoid plexus. Due to infection in the tooth, dental infection is carried by, then the pterygoid plexus will take this infection, especially through the Staphylococcus aureus, which is gram-positive organism, are usually the pathogens in this setting, and in mostly in anterior maxillary teeth drain the cavernous sinus. Cavernous sinus drain mostly in anterior maxillary teeth or mid third of the face. Okay, now maxillary sinusitis, next disease. In OS and oral medicine, we will also study it in detail. So inflammation of maxillary sinus is sorry. Inflammation of maxillary sinus Okay, maxillary sinusitis in OS and oral medicine, we will also study there. But here, inflammation of maxillary sinus can occur if it is more than 3 months. Then it will call it chronic maxillary sinusitis. Organism involved is Streptococcus pneumoniae, H. influenza, and M. catarrhalis in children. Catarrhalis in children and Streptococcus pneumonia is our first preference. In children, it is catarrhalis, and in adults, Streptococcus pneumonia, rhinovirus, and parainfluenza virus, etc. Okay, can also occur through fungal infection like aspergillosis and mucormycosis. Most common cause via dental infection are 2 1 and 3, which is maxillary first molar, okay, and maxillary second premolar, and maxillary third second molar, okay. First, second, third, okay. This is how we can remember it. Clinical features: pain on digital palpation. There's in maxillary sinus on digital palpation, there's pain present. Patient bows down his head. Patient bows down his head. Radiographic. Her head. Radiographically, transillumination Waters view is best. In for to view the maxillary sinus radiographically, transillumination method in Waters view is the best. Okay. Then histopathology: inflamed sinus lining, hyperplastic, proliferating in form of polyps, contain granulation tissue, lots of capillaries and endothelial tissue and inflammatory cells present. Now, there's a difference between focal infection and focus of infection. We'll study here. A focal infection is a localized, generalized infection caused by the dissemination of microorganisms or toxic products from a focus of infection. Focal infection is by the focus of infection, and it is localized, may be generalized focal infection, but it is due to focus of infection, okay. It is a reaction. A focal infection is a reaction of a focus of infection, okay. Now, focus of infection is main refers to the circumscribed area of tissue which is infected with the exogenous pathogenic microorganisms and is usually located near a mucous or cutaneous surface. And it is usually located near a mucous or cutaneous surface, okay. Acting as a source, entry point, action, mechanism of focal infection are focus of infection, focus of infection spread directly or can take indirect route, spread directly, microorganism, toxic product, direct damage. Examples: scarlet fever, erythrogenic toxin, rashes वगैरह, etc. Microorganism, toxic, direct damage, okay. And indirect route are microorganism, toxic, inducing hypersensitivity reaction, rheumatic fever. Antibiotics are attacking the wall of heart, so subacute bacterial endocarditis. Then oral foci of infection are infected pulp, tooth, pericoronal infection, periodontal infection, oral mucosa, alveolar bone are all examples of foci of infection. Significance: it initiate or aggravate a pre-existing systemic condition. Arthritis, rheumatic fever, valvular heart disease, subacute bacterial endocarditis, gastrointestinal disease, ocular diseases, skin diseases, renal diseases are general and non-specific. Thank you. This is now our spread of oral infection is completed. Thank you.